And so I thought I'd just walk through some of the data that we have about cardiovascular risk. And then Sonia and I recently wrote a commentary on a paper that is just coming out that looks specifically at this kind of a case. And so just to sort of open that up and then see if other people have other experience that that resonates with this, or and as we think about it. So the biggest findings in terms of HIV and cardiovascular risk, like there's a long-standing finding from a 2007 paper from Jeannie Triant and colleagues at in the Boston cohorts, where they found an increased risk of cardiovascular disease associated with HIV. So having the diagnosis of HIV was associated with a higher risk of coronary events. There were a couple of caveats to that initial work. One of them is that actually the association seemed stronger in women than men, although that was not in the sort of top line of the paper. And then also that there was not a good way to control for smoking in the database that was used to generate that initial finding. So there's always some possibility that maybe that there was a sort of behavioral confounder that was driving higher risk that wasn't really related to HIV, but was rather related to the fact that smoking is also more common in people living with HIV in the United States. So that's sort of the backdrop. And then one of the practice-changing finding that came out in 2023 was from the REPRIEVE trial. So this study was initially designed by Steve Grinspoon, I think back when I was like a fellow, because I remember the early discussions about it. And he's at Mass General. And their initial idea was to do a small trial and just use a biomarker as an endpoint. And actually, this is one of those cases where the funder, the National Institute of Health, was like, please do an endpoint trial. So enroll enough people in order for us to find out if statins actually prevent the outcome, as opposed to modify a biomarker. So one of those rare cases where you apply for something and they're like, no, please do more, and we will give you more money. So the results are summarized here to the left, but I'll just go to the next slide, which has more of the actual details. So they enrolled people who were aged 40 to 75. They had to have low or moderate cardiovascular disease risk using the pooled cohort equation calculator. And so that's, similar to if you do .ASCVD in your EPIC note, it will give you a 10-year risk of cardiovascular event. They enrolled 7,769 people. It was a global study covering both high and low and middle income countries. The median age of the enrolled participants was 50. The interquartile range there, 45 to 55. And 31% were women. So really good representation of women, in particular in this, which is the largest study ever done in people living with HIV, largest interventional trial. So the median screening LDL was 108, so not very high. And the interquartile range there was 87 to 128. So these are not people who you would have seen and been like, oh, you probably need a statin, even though you don't need a statin because your cholesterol is so high. They were not that high. 87.5% were fully suppressed for their HIV status. So important to keep that in mind. I think we think that untreated HIV probably has a more inflammatory driving effect on cardiovascular disease. So that was not the case here. And of the 700 participants, those who were not suppressed, the median viral load among those participants was 62 copies. So we're not talking about most people here were either fully suppressed or near full suppression at enrollment. And so what were the findings? So just summarize that the demographics up at the top, but the really key thing is here in panel B on the left. So there was a reduction in the incidence of first major adverse cardiovascular event. And these were adjudicated as hard endpoints, and so very clearly identified to be a cardiovascular event, which is a major strength of the trial also. But just showed that actually, even in this low to moderate risk population, adding a statin specifically for people living with HIV reduced the risk of having a major adverse cardiovascular event over the study period. So this is the 2023 analysis, which was an interim analysis that led to the reporting of results, but they published an update in 2024, where I think the point estimates are almost exactly the same with the complete data set that they were able to accrue. So this is in fact practice changing, and it led to the DHHS antiretroviral therapy panel making very clear recommendations for statins for in people living with HIV. And I'll say that, having participated in the discussion around this, there were some people in the room who were like, we are an ART panel. We should not be making recommendations about this. But because it is so specific, like the risk is specific to people living with HIV, and like we have a beautiful RCT that ultimately those voices were over talked, and I actually think most of them were in agreement. So for people who are ages 40 to 75, when the 10-year ASCVD risk estimates are between 5 and 20%, the panel recommends at least a moderate intensity statin. And so recommendations of options for a moderate intensity statin include pitavastatin 4 milligrams. That was what was actually used in the trial, atorva 20, Rasuva 10. When the 10-year ASCVD risks are less than 5%, the panel still favors initiating at least a moderate intensity statin, although the evidence level for this is C1. And the absolute benefit from statin therapy is modest. The decision should take into account the presence or absence of HIV-related factors that can increase ASCVD risk. And then you have the same options for statin therapy. For age less than 40, the recommendation is that there's insufficient data to recommend for or against in this population. And so then just to keep in the back of our minds, since HIV is not the only factor that should drive use of statins, so between ages 40 and 70, if your ASCVD is higher than 20%, you are recommended to have a high intensity statin, so not at least moderate, high. Age 20 to 75 with an LDL greater than 190, high intensity statin at the maximum tolerated dose, and age 40 to 75 with diabetes, at least a moderate intensity statin. And then just parenthetically, just keep in mind that there's exclusions for pregnancy and breastfeeding when statins are not considered to be safe. So we can kind of pause there, or I can just keep rolling through and then we'll talk at the end. I don't know if anybody has any comments about how they've been using this in their practice or not, or what kinds of conversations you've had with patients. Sarah's saying you talk about this all the time with your patients. And what in general is their response? I mean, I show this all the time as well. And Sonia's talking about it with everybody too. And have most people been amenable to statin initiation in your experience?
Yeah, I think it varies a bit. Some people are like, yeah, let's start it today. And other people, since I'm in the county program, a lot of folks have like local PCPs, and they're like, and I'm like, yes, I encourage people to talk to their PCP about it. But I like put in my note the cutoff, since I think some PCPs might not, be aware of this trial, or like write reprieve trial. Yeah, it varies a bit. And then everyone else is like, well, let me do some things with diet and etc. But then I'll like bring it up again and show them the risk calculator. But yeah, I've put a lot of people on statins in the last year. So
yeah, no, I mean, I think the other thing I'll just mention is like, but actually, Sonia, you go first. I've been talking for like an hour.
Oh, you just asked strategies, but then Sarah chatted, so I don't have to share. But what I tend to do is, it's like usually a lot of older people who are long-term survivors of HIV. And I kind of frame it as, we've really had a paradigm shift in HIV, and HIV isn't what's going to take your life. You're doing so well. And what we know is that even if you do everything right from diet and exercise, that there's still some inflammation from HIV that puts you at risk of heart disease. So I'm trying to focus on how I can keep you healthy for the longest possible, because it's so amazing that we've gotten to this point. And so that's how I try to frame the discussion, because I do feel like people with HIV, for some people, the pill daily, there's some pill fatigue, even if people do a good job with it. So sometimes it's adding on another pill is, to me, harder for this population than maybe some others. But that's how I try to have the conversation.
Yeah, no, I mean, I think that's great. And so one of the hardest conversations I've had is with a gentleman who has pretty refractory hypertension, and so his ASCVD risk score is you know, in this range between 5 and 20. He doesn't have anything else. He's overall very fit. He has like familial hypertension or essential hypertension rather. But his LDL is like already 60. And so part of me is like, I don't know how to think about this. And I think that is like in the panel notes, it says consider other HIV related factors. He's fully suppressed. He's actually a peri-elite controller. So was like viral loads max in the hundreds. So he's been actually so he has relatively low HIV levels, but it sort of unmasks the fact that we don't know whether the statin effect here is totally due to lipid modulation, or whether there's also immune benefits, which have been postulated about statins in many ways. And we don't actually have data to say doesn't help if you're this LDL. There was no threshold LDL level for inclusion in this trial. So I just put that out there as another thing, like, because when exactly as you say, Sonia, this is someone who's on 3 different antihypertensives and HIV meds. And so adding another therapy was not like super his first idea. So then I will just move to the next part I was going to talk about briefly, and then hopefully we'll get some more comments. But so I went back to 2015, and she had a visit with her provider. This is actually before I came here, in January of 2015, prior to this NSTEMI that she had in May. And so I plugged her into the ASCVD risk calculator, and she came out at 2.7% 10-year ASCVD risk. At the time that she was 5 months out from having her NSTEMI and had a 99% RCA occlusion. And so again, risk calculators are not meant for, like, they're not actually supposed to tell you necessarily what's going to happen to an individual. They're like population tools. We use them for individuals, but like they're not, the prediction isn't necessarily that they perform perfectly all the time. But this is like highlights, I think, the kind of the data that I wanted to get into today that's really just coming out. So I mentioned that there is this sex difference in the impact of HIV on the risk of cardiovascular and cerebrovascular disease. There's a couple of papers that have shown this before. But overall, if you separate out the risk that women have when living with HIV as compared to men living with HIV as compared to their same gender controls, the relative risk increase is substantially larger for women than for men. And again, this is like older data going back to 2018 and starting this with this initial paper in 2007. And so what we have now in the last sort of 4 months is really quantitative information about this. And this is from sub-analyses of Reprieve. So the first thing is that the authors here, led by Steve Grinspan and Markella Zani, and Markella has been like an outstanding advocate for analysis of specifically heart disease in women. So they looked at how the pooled cohort equation and the DAD risk assessment. So the DAD risk assessment was developed to be more accurate. We knew that the pooled cohort equation was missing some risk in people living with HIV. That was like, discussed before, like, oh, we'll calculate their risk and then just like smoosh it up a little bit in your mind. And that's probably more the accurate risk. And the DAD was developed to try to more accurately assess risk in people living with HIV. So what they did in this analysis, which was published in Lancet HIV online in January, was they looked at only the placebo arm of the pitavastatin trial. And they tested the performance of the PCE to predict cardiovascular events in that group of 3,800 people. What they found was over prediction of risk in low and middle income countries and under prediction of risk in high income countries. So that is one piece of information. And then in high income countries, they found an under prediction of risk among women and Black or African American participants. So, okay, we're not quite getting there in terms of predicting risk, but how bad is it? And so this is how they modeled out how you could improve the calibration of the score, so that like .ASCVD score that you get. And they found that the appropriate approach would be to multiply the original score by 2.8 in Black or African American women and multiply the original score by 2.6 in women of all other races, and multiply the original score of Black or African-American men by 1.25 in order to arrive at an estimate that's closer to the true risk. I just find this like staggering in terms of the underestimation of risk in these groups. And so like just going back to her, if we multiplied her risk estimate in 2015 by the correction, she would have been up at close to 8% risk. And by the current guidelines now, we would have recommended a statin for her. But so if I'm seeing her 10 years ago today, I can't, like what this data would suggest would be that although the guidelines are based on the DHHS guidelines are based on the overall findings of this study, that there are likely sex and race specific correction factors that need to be applied. And so what do we know about what's causing those? It's hard to say, but the same group also did a, so yeah, as I said, that would have put her into the category of being recommended for a statin. So there's a CID article, and this is the one that Sonia and I had written a commentary on. And so again, from Markella, who's the senior author here, and Steve Grinspoon, where they looked at the factors that affected the risk of CVD in this global trial. So they included both the placebo arm and the statin arm in this analysis and controlled for statin use in their models. And sorry for the like stamp, but it's in like accepted manuscript stage. And so this is their graphical summary of what they found. So that they found several risk factors for cardiovascular disease. Some of those are modifiable. This includes current cigarette smoking, which my patient still has, hypertension, which she has, but although it's controlled, a lower HDL-C level, and an HIV RNA that was detectable. So all of these things can be things that we talk to our patients about. Like we know specifically for you that stopping smoking, improving your HDL, which there are, as we know, relatively limited pathways to, and high blood pressure in particular that's uncontrolled, are all risk factors that we can modify, as well as HIV RNA that is above the lower limit of quantification. I think that the last part is like one, I know I've talked to this group before about my patient who has like non-suppressible viremia. So that's a hard one for those individuals because we don't know whether their risk is really associated with any detection of HIV or truly uncontrolled replication. But those are in general modifiable risks. So as far as unmodifiable risks, older age, sorry, can't change that. Being in a high income country, probably related to lots of things about what we do in high income countries, and Black race specifically in high income countries. And although that probably requires some further disentangling, because Ada Adamora presented data a few years ago looking at the overlap between poverty in the United States and HIV incidence and prevalence. And I think that some of this residence in high income countries and race may be associated with other social determinants of health, like lack of resources, food deserts, things like that affect health outcomes, specifically in high income countries like the United States for these groups. A family history, also not modifiable, but a risk factor, but really notable was that sex was not a risk factor. It was not protective. So female sex is protective, right? On this ASCVD calculator, one of the input variables is your sex, because if I change this to male, the original data may actually have triggered a statin recommendation. But what I think the findings are that are emerging here is that in the setting of HIV, there's a lack of protection for females from cardiovascular disease. And in particular, we need to really be thinking about their risk a little bit differently than we would think about people without HIV. I don't have any slides on this, but there was also at CROI a presentation looking at whether or not early versus delayed initiation of antiretroviral therapy was associated with decreased risk of cardiovascular disease in the START trial. And the findings were that earlier initiation of ART was not protective for cardiovascular events in the overall study or in males, but there was a protective effect for females, where if you started therapy earlier, you were less likely to have a cardiovascular event. it was really interesting because the authors said that since they had no a priori hypothesis that that would be true, and there was some uncertainty of the findings, that they didn't want to sort of over emphasize it. But like, I think there's a lot of data actually to suggest that there's other sources of that hypothesis, and that deserves a little bit closer look. Because I think one of the questions is whether there's a different mechanism here, whether women are developing cardiovascular disease in a different pathway, or whether HIV-associated inflammation is higher, or whether there are other factors that are really causing this level of increase of risk. So I will just pause there, and then, oh yeah, so Chris is saying it can be hard to convince patients with calcium scores of 0 to add a statin, but there may be a higher rate of uncalcified plaque with HIV. Yeah, so Chris, I don't know if you had anything else you wanted to say about that.
No, Eileen, I was looking for an answer from you. Tell me what to do.
Yeah, so I think that, so one of the things that Markella's work has focused on is that it does seem like the prevalence of calcium associated plaque, I think, is going to be lower in women also, and not protective in the same in this particular group of women living with HIV. So there's a question about whether or not the disease observed in women living with HIV is the same as the cardiovascular disease observed in men. I mean, I think the good news is that statins appear to be protective for everybody. It's just that, when we were coming to the original recommendations for the DHHS, there was a suggestion to stratify by sex, actually, because it looked like the number needed to treat for women met the threshold for what we should do at an even lower level than for men, but that wasn't what was initially done. So we'll see with all of these secondary analyses and things like that, how those can play out into actual guidelines. Because, I mean, one of the caveats of the Reprieve, the Lancet analysis was that it's only one cohort, it's one analysis. So typically, we try to look for data from more than one source before we make a strong recommendation. I don't know that we're going to get another, I mean, this is, again, the largest interventional trial ever done in people living with HIV. And so I guess the question is whether we would ever get replicative data. And so then we're going to be looking at cohorts and maybe looking at the application of statins, but you can't really look at application of statins to women at lower levels of risk unless you actually are doing it. So I don't know. So I guess I'll just pause there and see if people have thoughts about what they would do and how they think they might incorporate this into practice. Nobody's going to do anything.
I'll talk.
Yay.
I think it requires time with the patients to talk through it. I think I feel like statins are kind of have a weighted thing in a lot of patients' mind, and sometimes it takes convincing. Sometimes they've tried a statin and didn't tolerate it and will never go back to it, or sometimes I'll try a different one at a lower dose and kind of build my way up. I just really think it's an individual approach. It just takes our time and effort to figure out. And I've had definitely patients who saw like I'm like 10% risk of these major events. And they're like, oh, that's not so bad. Like I can live with that, like 10%. That's great. So I just think it's just, we have to keep talking to each patient and seeing what's best for them and what they're willing to do to reduce risk.
Yeah, I totally agree. And I mean, I think in the cardiovascular literature, they're like, trying to get, like, they're studying 20,000 people. They're trying to prevent events, like, I think we're often in a much more pragmatic approach to the therapeutics in our patients. But, I do think about Stephanie Thornton when she came on and was encouraging us to do all the health maintenance and things like that. Like, we do also have an obligation to really be offering our patients the very best things, like sort of the Cadillac care that you would get if you didn't have all this other stuff. And it's their prerogative to decline it. But I I think in our efforts to address disparities, like trying to have these conversations and let people know what data there is useful. I have to say, I was just so like, I found her risk calculator from 2015 to be so sobering. Like the fact that like it was predicting her 10-year risk at a very, very low, 2.7%. Like that is not the level that you will convince someone to start a statin on. I mean, but without a real update to guidelines, it's like, they've modeled out this risk, they've added these multiplication factors, but we're not on super strong ground for using them, but I definitely am probably going to start doing the number, if not putting it in my note, just to see where that correction would place the risk. I don't know, anybody else think that's overly aggressive or we shouldn't? So at ACT HIV this past week, one of the people in the audience asked for the drug companies in the room to co-formulate a statin and ART.
Yeah, the pill fatigue is very real.
Well,
One more thing.
I honestly wonder too, with our patients, because we make such a big deal about them taking their medications all the time, that like, I think some of them really do consider it like committing to another pill is committing to take another pill every day, even in a way that some people don't. Like other patients in a primary care office would maybe take it, maybe not take it, but it's not as big of a deal to accept or decline the therapeutic. So I think for some of our patients in particular, those who are very adherent, they're like, okay, am I going to commit to this?
Yeah. We've also done a great job of reducing their pills. Like that's all we talk about. This is less pills for you. Like we'll combine it into one. And so like they're not they're used to declining, not increasing the number of pills they take.
Yeah. And I have a patient who I see with the fellows who every time he comes in, he's got really big plans to exercise more and to change his diet. And it's just that fine line of like encouraging those plans at the same time as being like, but in the meantime, since you haven't done it in 5 years, let's put a pill on, and so usually what I say is like, just because you go on it doesn't mean you have to stay on it forever. But while you're getting everything under control, you should do this. And I also tell people that cholesterol is only about 25% controlled by diet, because that was what I learned in residency. I tried to like externally verify this recently and asked one of my lipid expert friends, and he actually wasn't sure. But that's the number that he also had in his head. We also did residency at the same place. So I don't know if that's just like the lore that we were taught, and I think so I say like, you can, even if you do everything perfect, the max benefit you'll get is probably around 25%.
Yeah, I've definitely written a note, and like I looked at my note from last time, said like, we'll consider a statin, but wants to work on diet exercise, and then like it's like, oh wait, we already had this conversation. No, this is the next time, and like we like nerdy, So it just kind of, it's always gonna be the answer. I think it's no, I'm gonna join the gym.
David Block.
So just a question along the line of what you were just talking about. In a patient like this, do you consider checking Lp(a) and hsCRP?
Yeah, so I think for my patient, the cat's out of the bag in terms of like she's secondary prevention. But back in 2015, I think that those are useful options. I think, in terms of whether they don't change the underlying data, right? So that wasn't done in the original study in terms of like whether or not that can distinguish risk. Like we can't look at whether it performed well in Reprieve. I don't know actually if there's an analysis of Reprieve that will look at that. That would,
Yeah,
and I should
but
check.
Even outside of HIV patients, I mean, those are independent risk factors, obviously, that, going to your 25%, I don't know if it's 25%, but there's other independent risk factors.
Yeah, exactly. So I think there's like, I think approximately 4 million sub-studies that are going to be done on Reprieve. So hopefully we'll get some of these additional data points to tell us who benefited the most, so we can more focus our counseling on this. But after Gail's update on Lp(a), I've been thinking about it more in patients, and to use as additional support for interventions or risk reduction. Do you have your patients on statins, David?
I am probably leaning towards overly aggressive about it. I don't see much downside risk. I very rarely see side effects, and I think it's pretty clear that anti-inflammatory effects of statins are at least partly independent of any lipid lowering. So, for example, you see reductions of pro-inflammatory cytokines, IL-6, TNF-alpha, and that's occurring downstream of the HMG-CoA reductase. So there was studies in the early and mid 2000s that showed some independence of the statin anti-inflammatory effect. And so that was the basis for this piastatin study, actually, was,
right, the
as I
Jupiter
understand
trial.
it, was we know these patients are inflamed. Can you reduce the inflammation? So, they're inflamed no matter what their age is or what their gender is or what their cholesterol level is. So they're so well tolerated that, if anything, Eileen, well, the biggest obstacle is not my patients. It's my remembering to do what I had intended to do. But yeah, I'm trying to put everybody on.
Yeah, I agree with you, David. So there was the Jupiter trial, which was one of the TIMI studies that looked at the performance of statins in participants who, this is non-HIV, who had an elevation of their hsCRP, and they showed protection from cardiovascular events after that with statins in that group. There were some questions about Jupiter afterwards and how the hsCRP was measured, but the group has gone on to do a number of studies of direct acting anti-inflammatory mediators, including canakinumab and others, and have shown that anti-inflammatories do actually reduce the incidence of cardiovascular disease. So there is like a clear mechanistic link between inflammation and cardiovascular disease. And in that one study, there was an intervening impact of statins. So I think that's super interesting. And part of one of the reasons why I think the sex differences are so interesting is because, well, first of all, because I study them, but second of all, because I think it means that that pathway is like super amplified in women living with HIV if it's the same pathway. So like it makes it more likely that you'll be able to figure out what the actual causal link is in the inflammatory pathway because you've turned up the volume on the risk.
I bet if you could measure in your patient IL-6, TNF-alpha, you'd see them elevated. You probably see hsCRP elevated. And so, we don't have great tools to address all of that, but statins may be one tool.
Yeah.
And this, before the Jupiter study, was the Prince trial as well. So, yeah, I think there's good evidence
For statin and anti-inflammatory. And then Yuka's asking what the adverse events are. So in Reprieve, the major adverse event was an increased incidence of diabetes, which has been reported with statin use in other settings. So not shocking, but still protection even in those who did develop it. I think with my experience with statins, I have had a couple of people who end up like getting CKs checked and sometimes have elevated CKs. In one case, this was attributed to the statin and discontinued, and I, in a fit of like over assiduousness, like rechecked it like 1 year later, and actually the CK was still elevated, and this turned out to just be someone with CKemia, which is, I think, has been in my experience more common than I would have predicted. So I would just say if you start a statin and you have an elevated CK as a adverse event, whether you identify it or someone else, if you then use that as a reason to stop the statin, make sure that it goes away and consider re-challenge if it does.